cultural improvement in this very critical moment for our society. We are 3 minutes early. So, what we have to understand first is the different biological response of the periodontal tissues to dental implants. In dental implants, we do not have a very important anatomical structure, that is periodontal ligament. Without periodontal ligament, we cannot have the same behavior of the tissues around the implant or around the tooth, because we are going to lose the vascularity from the periodontium. We are going to lose the bundle bone, that is the bone around the periodontal ligament. So, although the objective of periodontal therapy is to give back to the patient a good aesthetic result, good aesthetic and functional result, we do know that we have some limitations, some biological limitations, because around the implant we have to manage a different tissue that is like a scar tissue. It's not gingiva, it's mucosa and bone and the surrounding bone. So we have to really understand how to manage these situations in which we have to replace some lost teeth in the anterior area. So after tooth extraction, we have some critical biological changes around the tissues. We do know that we have a shrinkage of the bone crest and of the total crest, bone and soft tissues. And this shrinkage, we have to manage this shrinkage, and we do know that this shrinkage is more or less 3 or 4 millimeters horizontally if we have an intact palatal and buccal bone, and 1-2 millimeters vertically. Furthermore, if we have some bone loss, like in this case, if we have lost the buccal bone totally or partially, we can have even further contraction, a further change of volume of this area. And this is very frequent in the anterior area. Extract the tooth and we detect a movement on the buccal area, we do know that we don't have enough buccal bone. And which kind of situation are we going to see intrasurgically? We can see this type of defects. These are profound dehiscence defects around the root. So we can have more deep dehiscences, more shallow, and then we can have different patterns of healing. So clinically, we have two main scenarios. The first scenario is when we have to manage an edentulous ridge. So in this case, we don't have the possibility to manage the post-extraction side. That is a very good opportunity. And most of the time we have a flat ridge to reconstruct. And we have also, the second possibility is an hopeless tooth that we have to extract for any reason. And in this case, we can do something more, I think. So let's see what we have to do clinically when we have an edentulous ridge. Which kind of situation do we have in the clinic? So it's very frequent to have some small defect, like in this case, when we lose one tooth. This is very frequent in anterior areas and premolar areas as well. And this is, as I said, a small defect. And how can we manage these kind of situations? So if we look at the CBCT, is not a big defect from the bone point of view. So it's pretty easy to put an implant here, but aesthetically we have some problems. So in these cases, we plan first the restoration, as you can see in the slide. Then most of the time we prepare the provisional restoration before the surgery, and we prepare a surgical guide. So if you can see properly the video, in these cases, even if we are going to put the implant with a totally guided protocol, we still need a small flap, because this flap allows us to increase the volume of the buccal area. So with this small flap, we can access to the crest. So we can put our surgical guide and start drilling. This is the Klockner implant system. So this is a very precise procedure to put the implant. We are placing a Klockner Vega implant. And as you can see, in this case, we have a very good prime stability of the implant. So we register the torque of insertion, torque, and as well ISQ values. I'm using the Penguin system. So now the implant is
Для меня, если честно, все странно.
Inside the bone. So we use a soft tissue graft harvested from the palate to increase the volume of the area. And since we have, in this case, a full thickness flap, we are anchoring the soft tissue graft to the buccal flap. This is a very easy procedure. And to stabilize this graft, we need 1 or 2 interrupted sutures. So after having stabilized the graft, we finish our surgery by placing 2 interrupted sutures. This is a 6-0 suture. So, as I said before, we have already a provisional restoration. We put the provisional restoration, we screw, we try always to screw the restoration. And then we have to adjust the occlusion We don't want to have big occlusal contact in maximum intercuspidation and in lateral movements. So this is a pretty easy procedure. And you can see the case after 1 week. Here the volume is pretty good. And in these cases, after 2 months, we decide to restore the case. So we have scanned the position of the implants and as well the emergency profile to put the final restoration. So you can see here, radiographically, the provisional and the final restoration. So that was a simple case, but we have other cases more challenging like this, in which we have to rebuild the bone and the soft tissues. Because in this case, volume is lacking horizontally and vertically. To increase the verticality in this case, we use a soft tissue graft from the tuberosity, and then we inserted the soft tissue graft inside this buccal envelope, and then we closed the wound for primary intention healing. So you can see that these cases are not quite easy because we have to combine different techniques to increase the volume of the ridge. And then after a pretty long period from 3 to 6 months of provisionalization of the case, we can have a tissue similar to a papilla. There we have an implant and a pontic, and then we can definitively restore the case. So what I'm showing you is that if we do not have the possibility to extract the tooth, our approach and our surgery is going to be pretty challenging. Here you have the radiographical control of the case. So I want to show you this case in which we have a collapse on the tooth 1.1. We have a partial fixed denture from tooth 1.2 to 2.2. And we have gingival recession as well. And patient asked us to improve this situation, mainly the aesthetic of this situation. So you can see the horizontal collapse of the tissue. And here you have the radiology, the CBCT and the OPT. So you can see that we have some bone, but this bone is pretty in a palatal position. And in this case, we needed some bone regeneration for a perfect position of the implant, and as well soft tissue grafting. So in these cases, to increase the volume and the hard tissues in that area, we still need a flap. So we prefer to move the vertical releasing incision distal to the canine, because it's, in case of having some scars, it's better to having the scar distal to the canine. And we elevate a full thickness flap. In this case, with a partial thickness incision in the papilla between 1.2 and 1.3. So most of the time, we use the provisional restoration to start the drilling process to prepare the implant bed. It is a pretty precise way of doing. So in this case, the problem was not the coronal bone, but the apical bone. So the implant, the position is pretty good. We have some nice bone color on the buccal side. So we have to augment because of an apical fenestration to put the implant perfectly and to screw directly the crown. So to do this, we have to go apically and to fix the membrane with an ostopin. This is a resorbable membrane. It's a porcine pericardium membrane. In this case, we used only a biomaterial. This is a bovine bone, specifically cerabone, mineralized bone. They're pretty stable in the anterior areas. So, and then we have to stretch the membrane, stabilize the membrane, and many times we use also sutures, resorbable sutures to stabilize the membrane under the flap. And this is not enough. We need a soft tissue graft to increase the volume of the area. And we decided to put the soft tissue graft in this position to increase both buccally and palatally the volume of the crest. Then make incision in the periosteum and close hermetically the flap. This is the provisionalization, the immediate post-op provisionalization of the case. And this is after a couple of months, 6 months. The quality of the tissue is pretty good. And then we have to reshape the soft tissues. Pretty good situation of the soft tissues. So we put an healing screw to increase the volume. So we are pushing our tissue in the buccal position. And then we are restoring, connecting the implant to the provisional restoration. After at least 1 month, but we wait from 1 month to 3 months, and in some cases 6 months, even 6 months, we have a better situation, better shape, better morphology of the soft tissues around the crown. But we still can see an horizontal defect because of a big root prominence of the tooth 2.1. So you can see that we needed some more graft in the area. So we used a micro scalpel and to create an envelope, a buccal envelope. And we used soft tissue graft harvested from the tuberosity in this case. So we have to reshape this tuberosity, eliminating the epithelium and giving the right thickness to this soft tissue graft. It's pretty easy to insert the soft tissue graft and we decided to stabilize this position with an apical suture. Then we positioned again the provisional restoration. And this is the situation after 1 week. There's a very good healing. And this is the situation after 3 months. So now you can see we have a better aesthetic of the soft tissues around the implant, and we can see the thickness and the stability of this tissue. And finally, Roberto can restore the case. This is the final delivery of the restoration. But we can have even worse situations in which we have implants already placed. Like in this case, in position 1.4, we have a big discrepancy of the mucosal margin between the implant and the natural teeth. So in these challenging cases, we have to make a lot of surgical techniques, and we have to combine them, like in this case, so periodontoplastic surgery, vertical bone augmentation, to give a better aesthetic. So this is time consuming, this is pretty invasive, and not cost effective, but we can do it. So in this case, we have to remove the implants. This is the big defect we had after the removal of the implants. So in the first surgery, we decided only to stabilize the coagulum a little bit with a resorbable membrane, just to have a better situation in the second surgery. So this is the situation after 6th month after the surgery. We have a very nice quality of the soft tissues to be managed. So we started with the surgery. This is the incision designed for vertical augmentation. And you see that there is a paracrestal incision that is shifted a little bit buccally. And here you can see we have a better situation from the beginning. You can see here, this was before the day of explantations, and this is the situation right now. So our surgery is going to be less challenging than before. So we tried to put the 2 implants, but we decided finally to remove this implant because it was very poorly supported by the bone. So I think you are not seeing well the slides right now. Can you see my slides properly?
Yes, Matteo, everything is good.
So chat. Yes. Okay. So we can go on. I don't see. Yes.
Те, кто
Everything is
не
okay,
видит
so let's
слайды
try again.
Маттео, найдите второго пользователя,
Lev.
такое же имя, Маттео Альбертини,
So
и
I'm
там
going to
будет
continue the
презентация.
presentation, okay?
Okay.
So we decided to remove the first implant and to go on with the bone regeneration procedure. So in this case, for vertical augmentation, we use non-resorbable membrane. And in this case, we used a mixture of bovine bone, cerv bone, and autogenous bone, but in this case, very few autogenous bone, I have to say. So we have to fix very well this kind of membranes and to passive the flap and to get a very passive closure of the flap to allow the primary intention healing. This is very delicate in this procedure. And here we have the result after 1 year. So we have to wait 1 year in this case because we didn't have so much autogenous bone. And I hope you can see the video. We are removing the non-resorbable membrane. So we have to remove the osteopins first. And you can see a good aspect of the regenerated area in which we can now position our implants in a correct three-dimensional position. So, after the provisionalization of the case and the crown lengthening, we are in this situation. We started with this situation, and we got to this situation with the final restoration. Here you have a video in which you can see the regenerated bone. This is 1 year after the implant placement. So, what can I say? We can do this. We can do this, but as I said, it's not easy. It's time-consuming, not cost-effective. The problem is that we had to implant position in a very bad position. So we have to avoid to get to these situations. This is my message. So how to avoid to get to these situations? We have the opportunity to manage the post-extraction socket the day of the extraction of the root. So this is a pretty much easier clinical situation to manage. And mainly, we have two different scenarios. The first one is the favorable case. Which is the favorable case? So we have to consider several parameters. But the two most important parameters are the position of the gingival margin and the position of the bone crest. So if we have a coronal position of the gingival margin with respect to the future margin of the restoration, this is favorable. If we have good keratinized tissue, this is favorable. If we have the bone placed at 3-4 millimeters from the gingival margin, this is pretty favorable. The less favorable situation is when we do not have bone, or even we have gingival recession. So gingival recession implies bone loss as well, bone dehiscence. So in the favorable cases, we are mainly in the type 1 according to the Elian classification. So in these favorable cases, what can we do? What I think we must preserve the good aesthetic and quality of the tissues, like in this case. So we have to put the implant in a very good three-dimensional position according to the restoration, and then try to not to lose the buccal tissue. And how can we manage? So we can use some soft tissue graft and even some bone harvesting inside the socket. So this is a very favorable case. We have a temporary tooth to be extracted. So in this case, we had an included canine, and the patient didn't want to do the orthodontic treatment. So we had to extract the included canine and to plant the implant position. So a careful extraction. Then we only have to position the implant a little bit more palatal to allow a space between the implant and the buccal bone. We are placing the implant. This is a Vega implant. So this is the position of the implant that is shifted from the buccal gingival margin. And this is the radiological control. So in most of the cases, we're going to tunnel the area. So we do not make incision at the papillas, but we only tunnel the below the gingival margin, and we use some tunneling instruments to elevate an envelope. In this case, was a tunnel because we had a gingival recession at the premolar. So in this case, we harvested from the palate with the trapdoor technique. And I have to say, I'm not using anymore this technique. So after having harvested the soft tissue graft, we insert the soft tissue graft within the tunnel with both objective to preserve the tissue buccally to the canine and to increase the quality of soft tissues on the buccal area of the premolar. So this is the post-op situation. We measure the ISQ values for the implant, because in this case, we perform an immediate loading procedure. So here we are screwing the provisional restoration. This is the post-op image. And this is the case after 2 weeks. And here you have the case with the provisional restoration after 1 year. We don't wait 1 year normally, but it was because of the patient. So in these cases, it's pretty easy to get these full papillas, a nice shape of the mucosal margin, and to deliver to the patient a crown that is similar to a natural tooth. So here you have the radiograph at 1 year and the follow-up after 2 years. With this technique, we can approach even less favorable cases like this. We have an horizontal fracture of the tooth 1.3 with a distal bone defect. And we decided to approach the case with the similar approach, the similar technique. We have an abfraction as well at the tooth 1.4 and a small gingival recession. So first, careful extraction of the tooth without damaging papillas. Then 3D implant position, a little bit in a palatal position. Then tunneling the area, harvesting the soft tissue graft, and we have to insert this soft tissue graft within the tunnel. And in this case, also we have to shift a little bit coronally the tissue to cover the gingival recession. So this is the position of the implant. You can see that we have no releasing incisions. And this is the situation after 8 months with the provisional crown. So the recession has been covered and even a little bit more coronal than the normal, because we had an abstraction. And this is the situation at 1 year with the definitive restoration made by Roberto Padros and Mr. Ferran Puigrefagut. Here you have the follow-up at 1 year. So in these cases, I said favorable cases, but we have to consider also the position of the root into the socket, because we have some favorable cases. The most favorable is type 1, CAN type 1, in which the root is buccally positioned, so we can put the implant palatally. We can also put the implant in the type 2, but it's pretty much less easier to screw the restoration. And even type 3 is restorable, but we have to avoid put immediate implants in type 4, in which we have both cortical bone, buccal and palatal bone, very close to the implant. So, about the soft tissue grafting at immediate implant, we have some papers. This is one of the first papers published on this topic. This Andrea Bianchi and Francesco Sanfilippo, and they observed an increased width of keratinized mucosa, better emergency profile of the restoration, and better patient satisfaction. As well, we have also other papers. This is from the group of CAN, in which they saw an increased thickness of soft tissue after connective tissue graft around immediate implants. As well, we have another paper from the Jaime Lozada group in which they saw a better marginal bone level with a soft tissue graft and the better fascial gingival level around the restoration. So it is advisable to use a soft tissue graft in these cases. But what if we are in the second scenario, the less favorable scenario? So in the second scenario, we can have a bone dehiscence, and we can also have a bone dehiscence and gingival recession. And we have to distinguish a little bit from the type 2, where we have a bone dehiscence. This bone dehiscence can be more or less profound, more or less deep. So the less favorable cases are type 3, according to the Allen classification, but type 2B and 2C can be also less favorable. So, in this scenario, what can we do when tissue augmentation can be performed? So, we can have the immediate approach, the early approach, in which we have to extract the tooth, wait a couple of weeks, and then to put the implant and the bone regeneration, or even the delayed approach, in which we wait 4 to 6 months after extraction. We have soft tissue closure very good mineralized bone, but we have very few regenerative space. So in this presentation, I want to focus on the immediate approach, in which we have an open wound, a blood clot, and a big regenerative space already created by the presence of the root within the socket. So I'm going to present you this protocol we are using from a couple of years, and this is the immediate soft and hard tissues alveolar reconstruction technique, in which in one shot we are going to extract the root, then to tunnel the area, to position a membrane to fill the space within the between the membrane and the palatal bone, then to close with the membrane palatally, and to use a connective tissue graft to increase the soft tissue volume and to protect the membrane. So in this video, you're going to see step by step the procedure. The video has been supported by Klockner and Botis materials. So in this case, we have to extract the tooth. We have no other possibilities. So a careful extraction of the tooth. And then we have to create a small envelope buccally. We have to also remove the granulation tissues. This is very important. And then we have to enlarge the buccal envelope. Then we trim a resorbable membrane. This is the Jason membrane. It's a porcine pericardium membrane. And we give the membrane the shape we need according to the bone defect. The next step is to place the membrane within the tunnel. So we use some horizontal apical mattress to put the membrane, and in some cases it's so easy that you could even position the membrane without suturing. Then we fill the space with the biomaterial. This is a mineralized bovine bone. And finally, we have to put the soft tissue graft harvested from the pellet. To put the soft tissue graft, we have to use one apical suture and then simple interruptive suture to stabilize it. After 8 months, we use a transmucosal technique to put the implant, because we don't want to touch papillas. We don't want to traumatize papillas. So once position the implant, we can rest the case either immediately or waiting for the osseointegration of the implant. So this is the real case in which you can see the absence of the buccal bone wall. So we extract the root, we trim the membrane. With the apical suture, we are going to push the membrane inside the envelope. Then we fill the space within the membrane and the palatal bone. We fold the membrane and we insert the membrane within a small palatal tunnel. Then we harvest from the palate a soft tissue graft. This has to be a thin soft tissue graft, a good quality soft tissue graft, and very regular soft tissue graft. So we insert the soft tissue graft in the buccal envelope, then in the palatal envelope, and we stabilize the graft with interrupted sutures. We provisionalize the case with generally with a Maryland bridge, and only after 8 months we are going to perform the implant insertion with the transmucosal approach. So we put the implant, we wait for the osseointegration from 4 to 12 weeks, depending on the quality of the bone. And in this case, we restore directly the case with a final restoration. This is a follow-up after 1 year, and you can see a pretty nice profile of the soft tissue around the restoration. And here you have the follow-up at 2 years of the case, and the radiographical control of the case at 2 years. With this technique, we have approached as well more challenging cases like this. Here we have a gamma smile, and we have an apical fistula. So in the CBCT, we can see an horizontal fracture in the middle third of the root, and the total absence of the buccal bone wall. And we can even see a nasopalatine cyst palatal to the 1.1, 2.1, and 2.2. So to approach this case, we do have to elevate a full thickness flap in the palatal position because we have to remove the cyst. So after having removed the cyst, here you have the image of the cyst and the rest of the tooth. We used the same approach. So buccal envelope, a pericardium membrane, bovine bone, and in this case we fold the membrane. It's a big membrane to close all the palatal window. The same approach with the connective tissue graft, and then we stabilize everything with the suture. This is the bone situation after 8 months. So we can see a radio density there. We have biomaterial, but we have also new bone formation within the biomaterial. This is the situation with the provisional restoration after 8 months. This is a Maryland bridge. So at this time, we don't want to touch the interproximal tissues, and we are positioning the implant with the transmucosal approach. Here we have the situation with the provisional restoration after 6 months, and this is the final delivery of the definitive restoration by Roberto Padros. Here we can see the radiographic control of the case at 2 years. So now I'm going to present you another type of case. This is a different situation because we have an apical shift of the gingival margin. So here we have gingival recession and a bone dehiscence. This is a type 3 according to the alien classification. The tooth 2.1 had an invasive cervical lesion and had to be extracted. You can see in the CBCT the extension of the lesion. We could not maintain the tooth, and you can see the partial partial absence of the buccal bone wall. So it's partially maintained in this case. So we perform the extraction of the tooth. Here you can see the extension of the lesion. And then, in this case, we decided to approach it by positioning the implant at the same time. So here we are assessing the bone position at the interproximal level and the bone position at the buccal level. In this case is not so apical, so we decided to put the implant. Here we have the surgical guide to help us to position the implant. We drill the implant guided by this surgical guide, and we put a Vega implant in a palatal position. So you can see here the palatal position of the implant. That is very important in this kind of cases. We are assessing the primary stability of the implant. So we put an healing screw of 2 millimeters. It's a narrow healing screw. And in this case, we start tunneling the area with the micro blade. So we are preparing the tunnel for the soft tissue graft. Here we are inserting the soft tissue graft and filling the space between the bone and the implant. So we inserted the soft tissue graft palatally, and we stabilized the wound with single interrupted sutures. So here you can see the augmented area, both buccally and in the palatal area, and this is the suture at the palatal area. We provisionalized the case with the Maryland bridge, so we didn't perform immediate loading. This is the situation after 1 month. We still have a small collapse at the distal area of the provisional restoration, as you can see. After the second stage surgery, so we connect the implant to the provisional restoration. You can see the pretty nice emergency of the implant from a prosthetic point of view. So Roberto is making the emergency profile for the restoration, and as you can see, is making some pressure at the apical area and distal area, so we can have a similar shape of the tooth to the 1.1. Once we have the good shape of the soft tissues, we can definitively restore the case. And here we can see the radiological position of the implant and the follow-up of the case. So I would like to shed light on the scientific evidence of the immediate bone and soft tissue augmentation in post-extraction site. So what can we say? We have several papers about this topic, but as you can see, we have very few papers about type 2 sockets. The last 3 papers are about type 2 sockets, and mainly we have case report and case series. And only lately has been published a case series from Sicilia, and this is what we have. All the articles tell us that aesthetic outcomes of this kind of technique is good, but I can say we still don't have a very strong evidence of this kind of protocols. Here we have another case which has been restored by Dr. Anna Karpova. Is an example of this technique. It's the same approach, hopeless tooth, all in one shot, the bone regeneration and soft tissue graft, and here you have the final delivery of the restoration. Here we have a periodontal patient. Here we have the loss of the buccal bone. As you can see, the same approach. We have used the same approach. So placing the implant after 8 months from the regenerative procedure. So here we have performed the extraction. You can see we have a shift of the buccal bone. We perform the immediate surgical protocol, the implant placement, and this is the final restoration. And this is the frontal view of the final restoration at the canine. You can see the pretty nice profile of the soft tissues. And here we have a CBCT after 2 years of this case, in which you can see a pretty nice maintenance of the buccal bone. So I want to highlight another issue about this kind of approach. This is the first case I presented to you. And if we look at the CBCT in the follow-up after this positioning of the implant, we can see that we got really nice maintenance of the buccal bone, but we have to be very careful with the transmucosal approach of the implant, because the implant, the apex of the implant can go a little bit too buccal. So in this case, we had 9.5 millimeter of bone availability. And so my advice is to treat these cases by means of totally guided surgery. Like in this case, we have a type 3 socket with a small gingival recession, extraction of the tooth, preparing of the implant bed by means of the surgical guide, implant placement, soft tissue graft. In this case, we performed an immediate loading protocol with a concave profile of the restoration. So this is the healing after 6 months. And here we have the delivery of the final restoration. You can use this approach even in worst cases like this. In this case of vertical fracture of the premolar, the buccal bone is not present, and partially not even the palatal bone. So we perform a same approach. This is the situation, the soft tissue situation after 8 months. So we can see the bone augmentation after 8 months. And we are going to plan the implant position by means of this software, this exoplan software. As you can see, the implant is totally rounded by bone. So the implants could be positioned by means of this kind of surgical guide. Now I would like to share with you this video. I hope you can see properly the video. So we have to extract this 1.1 because we had a vertical fracture. As you can see, this is the bone probing. We have 13 millimeters of bone probing. So you can see the movement of the soft tissues in the buccal area. Here with the a 15C blade, we are cutting the granulation tissue. And we also use micro scissor to take away and remove all the granulation tissues. So now we have to check our bone availability. As you can see, we have a big dehiscence. So we start with the tunneling procedure. In this case, we are using a Buser periosteum elevator. And this is a full thickness tunneling of the area. So as you can see, we don't want to touch the papilla area. We have to assess that we have a good envelope to position both the membrane and the soft tissue graft. This is very, very important in this procedure. So once verified the space, we start the drilling procedure, because in this case we are putting the implant as well. As I said, the implant is positioned palatally. In this case, we used a Vega Plus implant. And we left the implant at 3 millimeters from the gingival margin. Here we are placing the healing abutment of 2 millimeters. And now we are placing the resorbable membrane. In this case, it was pretty easy to put the resorbable membrane. So we fold the membrane buccally, and then we have to fill the gap between the membrane, and in this case, the implant. If we don't have the implant, between the membrane and the palatal bone. So we fold the membrane palatally, and we put the membrane inside a small palatal tunnel. So we go to the palate and we harvest a soft tissue graft from the palate with the extraorally desepithelialized free gingival graft. Lately, I prefer this approach because we can have a better quality of the soft tissue with this approach. So here we are doing the incision. Now we are beveling a little bit the first incision to calibrate the thickness of the graft. So once we have calibrated the thickness of the graft, we can change the inclination of the scalpel, and then to follow the parallel to the external epithelium. Now we are removing the graft. We put one gauze first. This is a collagen sponge. And Then we have to place an horizontal mattress suture that is tooth supported, as you can see. So this is the first suture. Now we are moving the knot distally, and in this case we put 2 sutures in the same way, and we made the knot buccally to the premolar with the second suture. So now we have to look at the inner part of the graft. We have some fatty tissues and glands. In this case, we have to remove this tissue. Once you have removed this fatty tissue, you can start desepithelializing the graft. So you have to go parallel to the surface of the graft and possibly in one shot desepithelize a big part of the graft. Then we have to keep on desepithelizing. At the beginning, this procedure could not be so easy. So we need some practice to perform this procedure. And it's really important to eliminate all the epithelium. At the end, we have to eliminate the epithelium at the borders of the graft with a vertical desepithelialization. Okay, so now we have to place the graft, and here in this space you have to be very careful not to touch the membrane with your needle. So 1 suture is enough to insert the soft tissue graft within the buccal envelope. Okay, so now we have to push with the tweezers apically to help the graft to go into the tunnel. And finally, we fix apically the graft. Secondly, we have to insert the graft in the palatal tunnel and then fixing the coronal part of the graft. This is the first suture that is in the center of the graft. And then we need other sutures, and we usually use, lately, we usually the 7-0 Seralen suture. So I used to suture the graft at the angle lines of the tooth. And lately we put only 4 stitches. That is enough stabilize the graft and the wound. So, as you can see, we performed a bone regeneration and the soft tissue augmentation. The graft is exposed in the occlusal area, and we have a very stable wound in this case, and we have enough space for the bone regeneration. We have enough vascularization from bone regeneration, and also enough vascularization for the soft tissue graft, because it's a quite long soft tissue graft, and there is vascularization from the buccal tunnel and from the palatal tunnel. So I would like to share with you this case that I consider is a quite challenging case, which has been treated with this kind of technique. So we have an apical position of the tooth 2.2. The patients starting having some pain in that area. We have gingival recession at tooth 2.1. We have papilla loss distal to the 2.1. And as well, I have to add that the 2.2 was an ankylosed tooth with an invasive cervical lesion. So in the CBCT, we want to see if it was possible to treat this tooth. And after having discussed the case with our endodontist, Dr. Jordi Mas, so we classified this invasive cervical lesion as class 4. It is a through lesion, which is not recommended to treat. So the only treatment recommendable is the extraction. So you can also see the very, very, very thin buccal plate of this case. So we had to extract the tooth, and we started with a very careful extraction with a microblade. The extraction was not so easy because there was some ankylosis point. And here you can see the lesion that was really through from buccal to palatal area. So after the extraction, we are assessing the position of the bone crest interproximally. And as you can see, the distance from the bone crest to the ideal contact point is 9-10 millimeters. So it's not possible to have a full papilla in this case. This is the position of the buccal bone that is 4 millimeters from the gingival margin. So considering the recession, we have a pretty moderate dehiscence. In this case, mainly because of the recession at the tooth number 2.1, we decided to intervene with a little bit larger envelope. Because we wanted to move coronally the soft tissue. So we harvested the soft tissue graft from the palate, and we anchored this soft tissue graft in a palatal position. We are filling the space between the two corticals with the bone substitute. And here we are folding the soft tissue graft buccally to cover all the essence. And as you can see, the soft tissue graft is also supporting the papillas. So we close the flap with a Laurel Gottlow suture at the two papillas. And another suture in the buccal area. So we provisionalized the case with the Maryland bridge. And as you can see, the post-op picture, we have a coronal movement of the gingival margin. And this is the situation after 4 months, in which we still have a not ideal profile of the soft tissues, but we still have to work on it. And this is the situation from a bone point of view after 8 months. This is a pretty favorable situation for implant placement. So this is the soft tissue situation after 8 months. And as you already know, we don't want to touch papillas to not provoke gingival recession at papilla area. So you can see the good profile of the soft tissue in the buccal area. To put the implant, we start with the mucotome. It's a circular scalpel. So once we have access to the bone, we start the drilling process using this surgical stent. And we decided to use a micro-vega implant. It's a narrow implant of 3.0 millimeter. So with this implant, we are far away from the papillas. And finally, we put a transmucosal healing abutment. You can see the position of the implant shoulder, that is within the contour between the central incisor and the canine. And here you can see that there is almost no trauma at the papilla area. So in this situation, we are going to restore the case immediately in this case. And we transformed, Dr. Roberto Padros transformed the Maryland bridge to the implant-supported screw restoration. So we put the restoration, and this is the papilla formation, small papilla formation after 3 months, but we already knew the limitation of the case. This is the situation that is a little bit better after 6 months with the provisional restoration. And here we have the delivery of the final restorations. I have to add that we performed orthodontic treatment in this case to move the central incisor. So let's look at the radiograph. So the bone level is stable at 1 year. Here we have the comparison from the before situation and after. You can see the coronal movement of the gingival margin even in this situation. This is the follow-up after 1 year. And here you can see that with this technique, we don't need vertical incision, so we don't have scars on the tissue. We have a very nice appearance of the soft tissues because the underneath presence of the soft tissue graft you can see the soft tissue profile. And the lateral view of the restoration. And the occlusal view of the same. So, sorry. So, I want to give you a take-home message about this type of approach. I want to tell you that the immediate soft and hard tissue alveolar reconstruction technique is a minimal invasive procedure for bone and soft tissue regeneration of alveolar defects. And that is an alternative to the early and delayed guided bone regeneration protocol. I want to highlight that this technique avoids trauma for the papilla, as well as the needs of vertical releasing incisions, scars formation, and the displacement of the mucogingival line in most of the cases. I want to add that promising results have been observed from a clinical point of view for single implants in aesthetic areas, in cases of moderate or even severe dehiscences of alveolar buccal bone plate. But I have to add that to perform this technique, we need some clinical experience in soft tissue grafting, in preparing the envelopes, tunneling, and what could be added as well is that nowadays we have only some clinical evidence and a scarce scientific evidence of this kind of approach. So I hope you enjoyed the presentation, and if you like, we can open a discussion as well. Also, I wanted to give you my Instagram and Facebook address, and here you can see other clinical cases and some clinical tips which maybe you like to try in your clinic. So, thank you very much for your attention, and I wait for your questions. So, I have so I see a couple of friends here. So, hello everyone. Thank you very much. You can write in the chat your questions if you like.
коллеги. Можно задавать вопросы на русском и английском в чате.
So some are asking about the type of bone level implant which I put on the front side. So I think in these cases is preferable. 1 minute. In these cases, it's preferable to use a platform switching implant and a bone level implant, because in our hands it's easier to manage the emergency profile with this kind of implant, and as well as you can see in the presentation, these kind of implants can leave more space for both hard and soft tissues, because the profile of this implant, if you look at the implant, it's an inverted shape at the coronal part, and so it's pretty much easier to have more soft tissue around the restoration and to manage the soft tissue profile. So, other questions? Okay, I have another question. Hello, Pablo. So, the question is, what is my opinion around the use of allograft in these cases? So, allograft has been used successfully in a lot of regenerative procedures. I'm speaking about mineralized allograft. What can we say? I don't have tried mineralized allografts in this procedure, and I use bovine bone, because in the anterior area, what I do want from the biomaterial is the space maker function, because once you put the bovine bone, this is very, very, very stable from a physical point of view, and this is not resolvable. So I think that if we combine resorbable membranes, which are not so rigid, they are not stiff, so we have to put some material that's a very, very good space maker, and which can ensure the presence of hard tissues over time. We do need that we have new bone formation within the granules. Maybe with allograft we can have more vital bone, but I don't know if this technique works properly with the allograft, because I have not tried it, you know. So I have another question. So the question is, if I use a double split and full thickness flap, if I use a full thickness flap for the membrane and the partial for the connective tissue graft, I have to say that when I don't have the buccal bone, I use only a full thickness flap. So I put the membrane and the soft tissue below the periosteum. Only in cases in which I have to shift coronally the soft tissue, because I have a gingival recession, and in cases of partially presence of the buccal bone, I use a partial thickness flap in combination with the soft tissue graft and not using the membrane. So generally I use the membrane when I have a big dehiscence, big and large dehiscence. I hope I have answered to your question. Juanjo, hello. So we have another question. A very good question, Carlo. Hello, Carlo. I have to say that nowadays I try to harvest from the palate the more distal possibly. In that case, I did not harvest in that area only because we had to perform a vertical GBR in that area. So I had to avoid to touch that area because it was very important to have a good palatal flap for the vertical GBR. But I agree with you. It's better to go to the area of the first and second molar, and if we have enough tissues, even around the tuberosity. I hope I answered to your question, Carlo. So another question, okay. Another question is, why sometimes the connective tissues is not covered by the gingiva completely? So this technique is based on not moving the mucogingival line because the soft tissue graft is a stabilizer for our bone regeneration. So we don't want to move the mucogingival line if it's possible. So it's if we have to cover completely the soft tissue graft, we need releasing incisions. And so we need a more traumatic flap with the possibility to have scars, and as well, then we have to reposition the mucogingival line. So the second stage surgery has to involve papillas. So we avoid to touch papillas with this technique, and if we perform a small displacement of the mucogingival line, we will do it only partially, as you have seen during the presentation. I hope you are satisfied with my explanation. Okay, okay. So, do you have other questions? Leo? It's okay.
Matteo?
Let's look at the chat.
Are you hear me? Коллеги, Может быть, есть еще вопросы? Ответы были на английском.
Okay.
Кому-то, может быть, необходимо перевести.
I have another question from the public. I cannot see the question. Switch your dynamics. So the question is, if in the last case I could have made a palatal rotational flap to augment the chances of augmentation the papilla area, and using as well amelogenin. So my experience is not bad with the palatal rotational flap, but I have to say that with the palatal rotational flap, I have less control on the quality of the tissue because it's so close to the area. I have to make a quite important trauma at the papilla area to rotate the flap in a buccal position, and so I prefer to use the free connective tissue graft because you can control better every parameter, and you don't have to traumatize the papilla area. In relation to the use of amelogenin, amelogenin is effective when we have a total cover of the wound. So it is not effective if we have a vertical loss of soft tissues. That is what has been demonstrated, and we don't know really if the amelogenin can give us some advantages in these kind of cases. So can be used buccally, for example, in gingival recessions with very good results, but this is even not clear according to some literature. But in this case, I think the effect of the amelogenin would not have been the best. If you use amelogenin, Carlo, the result could be, I think, pretty the same, and the cost is more or less 250 euros more for the patient. In other cases, it would be indicated to use amelogenin. So this is a kind of approach that is this is our protocol we use in the clinic, but it's a very new way of treating these cases. The normal way to treat these cases, the most demonstrated effectiveness is the early implant placement. With the early implant placement, you have to extract the tooth, lose the tissue, to make the bone regeneration, to move the mucogingival line, vertical releasing incision, and everything is, and then graft the area with soft tissue graft. I have performed this technique for a couple of years, and it's a good technique, but I think the limitation of that technique is the management of the interproximal tissues, that always you're going to lose some tissues, and where it's more evident, it's at the distal papilla area. So people are asking about the new presentation about the use of amelogenin. Would be maybe another webinar.
Matteo, are you hearing me?
So I think this was the last question. I really have enjoyed the presentation. I have enjoyed so much staying with you in this very singular moment, and we have had the possibility to share some knowledge from myself, and I hope to see you again soon in another webinar. So thank you very much. See you again.